So I'll just do a little simple one, which is the toe correction. So this is my standard toe correction surgery. So I call this the RDF procedure, which is release, decompress, and fixation. So this is for correction of lesser toes. And there are lots of different techniques that everyone uses. If you have something that's good, just stick with it. But this is what I like to do. So the problems of standard lesser toe corrections are really, shortening, swelling, recurrence, malposition, floating toes, defunction toes. And as foot surgeons, if we don't do toes properly, the patients don't really think we're very smart. So it's just something we probably should get right. So the procedure is a release, a decompression, and fixation. So I'll go through how I do it. Everyone has their own way, but I like to use a 19-gauge needle to insert from the side inside the joint, and then I lift and use the sharp end of the needle to serrate the plantar plate and the ligaments under the PIP joint. You can also release the flexor brevis, but what this does, it allows you to release the contracture without removing any bone. You don't need to take any callosity off or anything. You just do that to start with. And then I like to make a minimally invasive osteotomy in the mid shaft of the proximal phalanx. You just cut the bone. It's very simple, and that frees everything up. Use a small Shannon burr. Sometimes if it's a severe deformity, you can make a second cut in the middle phalanx. And you need to have a little bit of space proximally, because that's what holds the K-wire. Now, if you're not using K-wires, you can use other techniques, but this is good for a K-wire. So once that is done, you can straighten the toe or position it however you wish. You can do various valgus, plantar flexion, dorsiflexion, and put a K-wire. Usually, you want the toe to look straight, so don't be too concerned if the bone looks a bit funny on the x-ray, because it always heals. I think I've got a video here, so just give me a minute. I think we'll be able to see it. So this is releasing the PIP joint. So we're lifting up and using the sharp end of the needle to get into the joint to release all the contractures. So we're able to then, you can feel the joint free up, and you're able to take the joint beyond neutral. Following this, we make a second cut, a small cut just in the proximal area, and we just make a simple osteotomy, which allows decompression and then fixation, usually along the shaft, and it holds the bone. And it's amazing how well that these end up. You're not removing any joints, so the patient still has some reasonable function. And you leave the K-wire in place for 3 weeks. Right. After 3 weeks, K-wire removed in rooms, and the patient can start moving and doing things that they wish. So we see here, this is some positions. You can see that things look a little bit translated or a little bit angulated, but when you look at the patient clinically, everything looks pretty straight. So I'm happy to take the clinical over the radiological, because if I were to do everything straight, it would, the abnormalities the patient had preoperatively would still persist. And you can see here we've done a distal metatarsal osteotomy as well, and we've used the wire to fix that. at the same time. So in the post-operative situation, you don't need to close any wounds. I just usually use some moist gauze dressings around the toe, and the patient can weight bear as tolerated. The pin's removed at 3 weeks, and the callosities, which usually sit on top of the joint, fall off naturally after 6 to 8 weeks, and you're left with a very normal looking toe that's very hard to tell whether they've had surgery.
Absolutely.
So you can use these for the same technique for other situations like varus valgus, mallet toes, and more severe deformities. Very severe deformities, you often need a combination of metatarsal and phalangeal osteotomies. So when they have a very long toe or a very severe deformity, I use a double osteotomy. For a floating toe, like usually a post-surgical problem from somewhere else, you can use a couple of techniques. One is obviously the extensor tenotomy. Sometimes plantar skin flap is useful, and also a DMMO. A mallet toe is really is quite simple. It's same sort of technique. But you can do a minimally invasive arthrodesis as well by just removing the joint, and you can internally fix that with a wire, and that does very nicely. So you can fix those things quite well. This is just an example of a patient with some severe deformities, done some DMMO and toe correction. This patient had multiple toes that were all pointing in different directions. The severe one we showed before. I have one little rule for if there is many toes that need correction, is to consider a proximal flexor-digitorum longus release. I learned this from Michael Stevens in Ireland, who used to use it a lot in pediatrics. A small incision, just proximal to the medial navicular tuberosity, and you can access FDL just under the tibialis posterior tendon and just cut it, and that will stop any recurrence that you'll get, and they don't really notice any dysfunction. All right, so that's the toe correction talk. So yeah, so I'll stop my broadcast.
Yeah. All right, sir. So these were some very fantastic corrections. I could see that sometime you have, you said something very beautiful, that you take the clinical picture over the radiological picture, and those K-wires don't need to go sharp through the middle of the bone. So it just have to have a good hold, isn't it?
Correct.
Yes, sir.
A lot of, and if some of your colleagues have done fellowships in Europe or worked in the UK, a lot of lesser toe surgery there is done without any fixation at all. So they rely a lot on strapping and dressings, so it's possible to do without fixation if necessary. But I find the K-wire is a little bit easier in my practice.
Yeah.
Can I add a word?
Yeah, please, sir, go ahead.
As Mark said, in Europe, they do not use KY fixations because if suppose you are fixing a bone in particular angle, what do you want? Or in your own alignment to say, what happens? They can develop a callosity in some other place where bone is prominent, in case it is prominent. Yeah. If you leave it without putting a K-wire, it unites in the loading pattern of the foot.
Yes.
So normally you fix the toe in a straight line, but normally when they start walking, they have a little bit of flexion so that they need to grip their footwear or a shoe. So it goes in for about 5 to 7 degrees of flexion at the distal tip. And as they start walking and the osteotomy is intraperiosteal, they do not displace much.
Yes.
Or if you want to put in a K-wire, you will have to remove the K-wire as the soft callus forms, so that then it gets molded in the way it wants to. This is the theory in Europe they normally say. That's what Dr. Mark was saying.
Yes.
It is as you are comfortable with and as your patient wants. If you want them to walk early, then the wire might be little difficult. But floating osteotomies for the toes are acceptable in Europe.
Nicely explained, sir. Thank you so much. Yes. So let me see if there are any questions. No, not so far. So can we have some other presentation from you, Mr. Mark, where you would want to show?
Yeah. No
Can I
worries.
ask a question to Mark? Shantanu? Mark, one question. This is Abhishek.
Yes.
Right. Go ahead.
Yeah, Mark, you showed toe corrections with only phalangeal osteotomies. Do you believe in distal metatarsal head wires or something which you do MIS?
I do the DMMO, the distal metatarsal osteotomy, minimum invasive, yes, quite a lot.
Okay. I would like to.
Is that the question?
No, one question. If suppose a patient is developing a callosity in the plantar aspect of the foot, and if your diagnosis is a problem with your metatarsal parabola, then would you do
Yes.
a PMMO or would you like to do a DMMO? What are the indications for DMMO and for PMMO? This is for
DMMO,
every
you mean proximal?
proximal metatarsal
Yes.
osteotomy
Yeah.
and a distal metatarsal osteotomy, where distal metatarsal osteotomy is good, where proximal metatarsal osteotomy is good for the lesser toes or from second to fifth.
Well, I tend to use the DMMO mostly because I find that I like to do some internal fixation, and it's quite straightforward to do internal fixation with a wire with a DMMO. Whereas if you do it proximally, you certainly can get elevation, but it's perhaps a bit harder to control. So I prefer to keep a bit of control, but I have no objection to the PMMO.
Okay.
I can do a talk. I can do the. Do you want me to do a talk on metatarsalgia? I have one of those. Maybe I'll do that now.
See, if suppose the loading is more and you think you need an elevation, there are a lot of papers published saying that if you need a metatarsal elevation to happen, then the PMMO is better. When you do a DMMO, it is only longitudinal decompression you get.
Oh, you certainly get elevation.
You need to do a dorsal wedge osteotomy of the proximal metatarsal. Then you can elevate the metatarsal.
You can.
Yes.
But you also get elevation with DMMO as well.
Yeah, the
more
toes
so
will,
than you do with a while.
Yeah, while you can do, but you need a fixation. Whilst you need to do a fixation because you will not get the desired angle if you put a wire. So that is
Raja,
but you do get
Raja,
elevation.
Yes,
Raja,
Rajiv Bhai.
Raja, can I add a point?
Yeah, please.
This is for the orthopedic foot and ankle surgeons to know that when do you want to do clinically, how do you decide that you want to do a shortening osteotomy or you want to do elevation osteotomy?
Elevation osteotomy.
So when you see the callus, which is just underneath the head of the metatarsal, that means the head of the metatarsal is
putting
pressing more load. So that is
then
the
you
time
need
you
elevation.
need to do elevation osteotomy.
You need to do a PMMO.
Yeah.
With a fixation.
Baruch would do PMMO, Raja would do PMMO. And when you have a callus which is distal to the head of the metatarsal,
then you do a longitudinal decompression.
So then you need long. So that is what is important for each one of us to know this for a clinical distinct.
Yeah, that is why I asked this question. That is why
Thank you, Raja. Thank you, Raja.
Thank you so much, sir. Mr. Mark, you could go ahead with the presentation on metatarsalgia, but before
I'll do a metatarsalgia. Okay.
Yeah, there's a question though. There's a question.
Yes.
We should answer that question first, and that is from one of our very respected EC member, Dr. Arun Kumar Ramanathan, and his question is: periosteum is a tight sleeve around the bone. With an intraperiosteal calcaneal osteotomy, how do you achieve an adequate translation? The question is in the chat box.
Well, you have to cut the bone in the goal is exactly the same as with an open calcaneal osteotomy. You need to cut the bone enough and cut the periosteum around it at the osteotomy site so it's mobile.
Okay.
So you do need to try to achieve a mobile calcaneum. So you have to have to penetrate the calcaneum on the periosteum on the opposite side to mobilize it.
See,
And once you've done that, it's quite straightforward to translate, and it heals very rapidly.
see, when you do an open osteotomy of the calcaneum also, you're not stripping the calcaneal periosteum all around. It is only one side you can open up. And the more stripping you do, you have more soft tissue problem. So as Dr. Mark was saying, when it goes through and through, the maximum displacement you're going to do is 5 to 8 mm is the displacement. And you'll be able to do it. It is like exactly like hallux valgus, how you are doing the metatarsal head and the metatarsal shaft displacement. It is exactly like that. 5 mm of displacement should not be a problem if you use a thick K-wire from the lateral side.
Right.
All right.
Thank you, sir. I think you can go ahead with your presentation, Mr. Mark.
All right. So I'm going to give you my my talk on DMMO, which I think I gave at the IFAS last year. So if you've heard this before, I'm very sorry.
No, please go ahead. We can hear it again. Yeah, Mark, you're there? Mr. Mark, are you there? Some problem with the connection, maybe.
So everything is okay at our end. I think
Yeah,
there's some issue with his mic.
Yeah, probably his connection is a little unstable.
We can go ahead with Dr. Raja till he gets back.
Yeah, sure. Dr. Raja is a panelist. He is there to put his thoughts forward. So, Dr. Raja, are you there?
Yeah, I'm there. Okay.
Okay. So if I can ask you a question in the meanwhile, while Mr. Mark is getting back.
Okay.
So, while you started with your minimum invasive surgery, what percentage of your work is now minimum invasive?
Only one thing I would like to tell everybody, all the young surgeons, new surgeons to MIS. First, you need to know to do open surgeries. I think Rajiv Bhai will be there. You can ask him. First, know the procedures well in open technique. Then slowly become minimally invasive, because you need to know the structures very well, the contour of the bone and feel of the bone. And if by chance you choose an osteoporotic patient and you leave the burr inside and start rotating, that's it. The bone will get grinded. You will not have a bone on the distal end or the proximal end, depending on the osteotomy, and you will suffer. So first is learn to use the burr, have control over the burr and feel the bone. Learn the open procedures well, then start doing osteotomies with your burrs in open procedures, and then go for closed procedures. This would be my advice.
Yeah, thank you so much. That's a very nice.
Yeah. Any of the youngsters who have joined this can always get advice from Dr. TVR. He has always been very kind to advise on to this, and he probably is the father of MIS in our country. Keep that up, Raja.
Thank you, sir. Welcome. Any questions anytime or want to discuss on any X-rays, you can send me the X-rays and I'd like be very happy to answer them.
So, Raja, if you could tell the proper journey you had into this, because those were the days where you were not fixing, and how you evolved to
Yeah.
the fixation. And you
Okay.
know that we used
The
to have a
problems.
great
Yeah,
debate.
Mark-
Yo, Mark is there.
Mark is there.
Okay.
Sorry
Yeah.
about that.
No
My
problem, sir.
internet
Please
was
go ahead,
playing
sir.
up. Do you want me to start from the start or after? I'll start from the Maestro criteria.
Yeah, please go ahead, sir.
Okay. So you can hear me okay?
Yeah, yes, sir.
Oh, good. All right. So this Maestro criteria defines the relative ideal lengths of the metatarsal in reference to the transverse metatarsal arch. The standard patterns that are seen, the ideal foot is where the first and second metatarsal are equal, but this only covers about 30% of the population. The common abnormality that I would see would be where the second and the third metatarsal are long, and this covers another 30%. And there's another group where they have a short fourth and fifth metatarsal, and this is also can cause problems. In the primary form of metatarsalgia, this is due to problems perhaps outside of the forefoot, and this can either be due to some abnormality of the Maestro criteria, but is more often related to other problems such as fixed equinus in pes cavus, or a tight Achilles causing an abnormal shape which causes the metatarsalgia. The secondary metatarsalgia occurs due to diseases within the forefoot, such as a transfer lesion from hallux valgus or hallux rigidus, some inflammatory disease causing problems with plantar plates, and then we have fat pad migration seen in the elderly or after trauma. And then another area which is seen all too often, unfortunately, is iatrogenic. And this can occur due to most commonly hallux valgus surgery, where the first metatarsal is shortened excessively or elevated, or there's been an excision of metatarsal heads in an inappropriate way, or if someone has performed an isolated metatarsal shortening. So in my practice and in many places now, most metatarsalgia surgically is dealt with via minimally invasive techniques. I won't go over the equipment again, but for metatarsal osteotomies, I use a Shannon burr because it's a cutting burr, usually a 12mm Shannon burr. So the goal of the distal metatarsal osteotomy is to provide shortening and elevation of the metatarsal. So this cut is performed in the metatarsal neck in the standard form, and the angle of the cut is oblique to the shaft and allows for elevation of the metatarsal as well as 2 millimeters of shortening, which is the width of the burr. And so when we look at this, the steps to the procedure are where we identify the metatarsal neck on X-ray, we make a percutaneous incision, And then we clear the periosteum and soft tissue around the osteotomy. We put the burr in and cut the bone from plantar to dorsal and releasing the bone. And then it's confirmed on X-ray. So if we look at the issues, if we look at the procedure, the indications are very similar. And for me, until this technique was available, or we ever had, or most procedures that were done, certainly in Australia, were wire osteotomies, and a lot of surgeons still do them. When we look at them, the 12-month results in studies are still similar. So it's not like it's a bad operation or one's better than the other. But when we look at the results, the DMMO cases have more swelling earlier on. And I have the main reason for that is that in the studies, there's no internal fixation used, and they do have problems related to that, and I'll go into that. But the toes and the metatarsals do have more stiffness with wire osteotomy, perhaps due to more stripping of periosteum and ligaments. But the DMMO in the studies had more delayed union. But if you're just cutting the bone with a minimally invasive technique, it's very quick and less problems with incisions. And because you're not putting any fixation, there's no cost for implants. The DMMO is not useful for Morton's neuroma, intermetatarsal bursitis, or nerve pain or inflammatory disease. Although we do use it for some patients with forefoot reconstruction. So the indications are for transfer metatarsalgia, congenital overload, age-related overload, intrinsic muscle weakness, post-trauma, and iatrogenic overload. So very similar to wire osteotomy. With static metatarsalgia, this is a problem of the second rocker, where they call it as a hindfoot-driven metatarsalgia, where the whole foot lands abnormally, and the patient develops broad metatarsal pain. And these cases are best indications for the DMMO procedure of the second, third, and fourth metatarsal to elevate, shorten the metatarsals, and even up the weight bearing across the foot. In my practice, I have stopped doing plantar plate repair, and so I used a single DMMO for the second toe usually, which is usually long when the patient has a plantar plate tear. So we do a claw toe correction and a DMMO with a K-wire to deal with that situation, and the plantar plate will heal over time. So this is a case where they've had a mica procedure and they've had a ruptured plantar plate with a crossed over toe. We've done the DMMO, done the toe correction and KY fixation for 3 weeks. And in 3 weeks, as we mentioned before, they still have some soft callus so they can adjust the position as necessary. So if we look at this one's before and after of a patient with a claw toe plantar plate tear and a hallux valgus. And this X-ray on the right is around 8 weeks. So they're still a bit swollen, but still having a reasonably nice result. And this is a similar, this is the X-ray at 8 weeks. So we see that there's still, with minimally invasive surgery, one of the things that you need to know is that full union on the bone, on the X-ray, takes a long time, probably 3 or 4 months. So the patient doesn't particularly, so the X-rays don't particularly look united around 8 weeks, but they always unite. There's another procedure called a DICMO, which is used when you only want to have a very small amount of shortening. It's perhaps a more advanced procedure, and I don't really do it much so I won't talk about that. There is another procedure which is, I think, useful in my practice, which is called the DOMO, which is a oblique metatarsal osteotomy, which is performed in cases where you need a bit more shortening. So the osteotomy is done a little bit more proximally and in an oblique fashion. And once the bone is cleared, you can get quite a lot of shortening, and it's very useful for dealing with varus and valgus deformities as well, because you can translate a little bit as well in the right situation. So here we have a case with large callosities, and we can see that in this case, patient has a iatrogenic metatarsalgia with valgus deformity and long third, fourth metatarsals. So here we would do a DOMO procedure with a phalangeal osteotomy for correction. In this case, we have sort of just a transfer metatarsalgia with deformity. So we do a mica and then oblique metatarsal osteotomies, as well as medializing phalangeal osteotomies. This is a pretty severe case with a patient with a callus arthroplasty and very severe deformities of the toes. And here we've done some oblique osteotomy, phalangeal osteotomies, and mica. And you can see we've been able to correct an enormous amount here with only really small cuts in the skin. So it's, you know, there's a lot of surgery that perhaps I would have been quite nervous about in past times, but now it seems like a lot of work. But once you work out the exact osteotomy you want to do, it can proceed quite routinely. These other cases with a dislocated second MTP joint, which you can treat with a DOMO because you get enough shortening to allow it to reduce. And as long as you can correct the rest of the metatarsal, transverse metatarsal arch, you can get a nice result. However, with the DMMO, you can still get problems. Swelling and edema is the biggest, most critical one in the literature, but in my practice, I do internal fixation, and it's very, very rare to have excessive swelling. Prolonged metatarsalgia is usually due to non-union. With internal fixation, it's not really something that I see. So I would always suggest a short term of internal fixation of K-wiring for these. And then non-union can occur, and that will require some fixation or extra time, and occasionally a malunion if not done correctly. So I'll just, these are my references, but that will get us through that one. Okay. So, so is anyone, I guess, I'm sure there are a few people doing DMMO, is that correct?
Yes, I do a lot of DMMOs.
Yeah.
Okay. Can I ask you a question regarding your DMMOs and DOMO?
Yeah.
DOMO you're doing for shortening the metatarsal length.
It's mainly for, yes,
shortening.
Usually shortening.
Yeah.
You do get elevation as well.
Yeah.
But,
so
now
the question is, if suppose post-operatively, after the DOMO, if the patient gets a plantar callosity, what do you do? Or how do you correct the elevation, or how do you maintain the elevation of the metatarsal? Because it is a floating osteotomy.
Well, the wonderful thing is that, they use internal fixation. So they get KY fixation
Okay.
for 3 weeks.
Okay.
And
KYS.
so that will stop it from being too unstable, because by the time the KY comes out, it's actually quite stable. There's a good early callus available.
Early callus, yeah. So you remove your KYs in 14 days or 20 days?
Or 21 or 28 usually.
Okay.
So they do have callus, so we can control it. And also you prevent further callosity by ensuring that your transverse metatarsal arch is exactly correct. You can't leave a long or an excessively short metatarsal compared to the others. And I think if you can do that, it's very rare to get problems.
Okay.
I've been very, very surprised how adequate and how successful that procedure is compared to the wild osteotomies that we used to perform.
Yeah, I was doing floating osteotomies for about 10 years. And if suppose the selection of cases were not good, then I had a lot of displacement. So in floating osteotomies, the callus formation was also a little more. And the problem that I faced in India was half of them were barefoot walkers.
Yes.
In India, in South India, and mainly they are barefoot walkers. So post-operative callus formation was a problem for me. So that is why I started deciding on when to fix the metatarsal osteotomies, and I started doing a lot of Wales osteotomies for the lesser toes. And I started doing proximal metatarsal osteotomies, MIS, and I normally fix them with cannulated screws.
Yeah.
I use a 2.5 mm screws, cannulated screws, and fix the PMMOs. That's what I've been doing.
Yeah.
And in hallux
I would say 50 to 70% of probably more surgeons in Australia would still do wild osteotomy and proximal osteotomy.
I now do a lot of Wales osteotomy because I'm really happy with the results with Wales. See, it is on the surgeon. He decides which osteotomy for which patient. That's how I talk. It is not book that tells you. It is the surgeon who decides on which osteotomy it is, because if he is comfortable with a particular osteotomy, he does it. If you're good in an osteotomy, you go ahead and do it. And how do you decide whether it is a chevron or it is a other or distal osteotomies for hallux valgus? Scarf or a chevron? I decide if the deformity is more. If I require a double osteotomy, then I do a scarf in hallux valgus.
I do my for every single bunion.
Okay.
So that has taken over. Before then, I did a scarf.
Okay.
But everything is now mica, and that's really where it will go.
Do you do going on hallux valgus principles? If suppose the intermetatarsal angle is more, do you reduce the intermetatarsal angle by putting a fiber wire or tight ropes or anything like that? Or it is only mica you do now?
No. The principle is always the same, in that you need to get the metatarsal head to exactly over the sesamoid. And sometimes with the mica, that involves doing a translation of the head, which is almost 100% of the shaft, which at the time, when I first started doing it or saw it, was quite nervous, but it's ultimately been a very successful and very reliable tool.
how do you correct the varication? I've seen a lot of patients with rotation of the distal
The
metatarsal.
rotation is corrected by two ways. With the mica, I put a KY in the head of the metatarsal and use that as a joystick. So once you've made your osteotomy in the neck, you can then rotate the metatarsal head as you translate it, so you can get the sesamoids underneath.
Yeah, it is. So you use your medial sesamoid as a control and joystick it. So you put the K wire, threaded K wire anteriorly and control it. Correct? This is for the
Correct.
youngsters to know it.
Yeah.
Yeah. Yeah.
I do it with two K wires, one distally and one proximally, so that I know where the wire was previously corresponding to this one, like a Joshi fixator, and later on I rotate the distal wire or the metatarsal wire on the head. I rotate it, so I know how many degrees I've gone medially or how many degrees I've gone laterally to bring the sesamoids on the AP exactly down. That's how I do it.
Yeah. You need
Right.
the sesamoids reduced, definitely.
Yes, that is why I wanted everybody to know, because now people have started reducing the scarf osteotomies, because when Mika was coming up in UK, I was there, and normally they were not putting screws. I saw one of your x-rays, you had used two cannulated screws there, headless screws to stabilize, but there they
Yes.
displace it and put in just a K-wire on the medial aspect and just leave it like that.
Yeah, some
But
people
this,
use KY.
yeah, but this looks little stable, because
Oh, this is really good.
yeah, this is fixation looks little stable.
Yeah.
Right, right. Yes, sir. That was a very important comment and that important issue that you drew our attention to. And there are a few questions in the chat box, Raja sir and Mr. Mark. You could read from the chat box and answer them.
Yeah.
But in the meanwhile,
I saw that.
yes, right. But in the meanwhile, but before that, I'm glad to let everyone know that we have a very distinguished person in our audience, and that is none other than Dr. Paulo Ferrao. Would you mind unmuting yourself, Paulo? Yeah.
Hi.
So, Dr. Yeah, hi, Paulo. How are you?
Good, thanks. How are you doing?
Yeah, Dr. Paulo Ferrao is none other than the past president of South African Foot and Ankle Society. So since minimum invasive is the way forward, I just want a little comment from him as to what his experience is there and what is happening on this front in his country.
Thanks, Kumar. Yes, so first of all, I want to congratulate Mark, some fantastic presentations there, really putting the topic up front there. And Dr. Raja, great panel discussion. You can see, the knowledge is definitely there. Now, in my practice, unfortunately, MIS is still very limited, but I have no doubt that, it is there in the future, and it is important to be part of what we do as orthopedic surgeons. So it's good that we're promoting this to the young surgeons. All our fellows go and visit colleagues of mine who do MIS. And I think my restraint to MIS, it just come from, especially when I was looking in the early days in the forefoot kind of MIS surgery. Now, as orthopedic surgeons, we always get told when correcting deformities, you should address it at the cora. Now, especially if you look at those lesser toe corrections, you're kind of doing the osteotomies outside the cora. Now, I've no doubt that actually they do work. But initially, when you saw these x-rays, you're thinking, my goodness, how does this work? But as we've seen from Mark, and there's now some long follow-up showing it does work. Now, I'd just like to actually ask Mark and Dr. Raja from their experience. Now, because we're doing these kind of osteotomies away from the cora, yes, the x-ray alignment looks quite weird. Now, in a patient like a rheumatoid, which might be uncontrolled, now you've done the surgery for these lesser toe deformities, and unfortunately, they can get recurrence. Is it more difficult if they get recurrence of these lesser toes? Because as I say, now you've got these kind of Z deformities through the toes, or are you not kind of seeing recurrences even in those type of patients?
Well, I think whatever deformity you start with, you can usually correct via MIS. So it depends on what actual deformity you're looking at. But the beauty of the MIS techniques is that you can correct in all different planes quite readily, and you can get really quite satisfactory improvements if in a recurrent situation. My experience is that they do just as well with inflammatory as they do with inflammatory disease as normal with toe corrections with MIS.
Okay, I'll add a little bit. See, normally in this rheumatoid, when you're talking about rheumatoid, the deformity is mainly because of two things. One is disuse atrophy of the bone and soft tissue fibrosis and contracture. So soft tissue becomes tighter. Because of that, they get deformities. So there are two things you'll have to concentrate on. You'll have to respect the soft tissue full and then do the osteotomy and do a shortening of the metatarsals and the phalanges so as to respect the soft tissue contracture. So when you respect the soft tissue, the bones go and lie in alignment, and then you do not get a deformity. Point number one. Point number two, if they get a deformity again, it can be because of again soft tissue becoming tight, because the medical management of rheumatoid arthritis is not done properly. If suppose a deformity arises, then again you can go and do an osteotomy, because you're not ripping the soft tissue off and the blood vessels off. So you're doing a minimally invasive procedure, and it requires only a 18 gauge needle or a MIS blade at the level of the phalanges and the metatarsals. So respect the soft tissues, and how much ever they are tight, you will have to go and do a osteotomy and shorten the bone so that they lie in alignment inside the soft tissue package.
Right.
Thank you
So
very
Now I'll answer. There's a couple of questions I need to answer, Kumar.
right, sir.
One is, what is my longest follow-up for DMMO? Apparently, some of the studies show that the results fail or lessen over time. And I would say that my longest follow-up is about 3 or 4 years now, and the issues are very minimal. And I would say that as long as you respect the transverse metatarsal arch and do it sparingly, and I personally would encourage internal fixation with K-wires for 3 weeks to stabilize the foot and get some soft callus before they can move. And I non-weight bear the patient for 1 week so that they can develop a little bit of early callus before they walk. And the other question from Dr. Rajiv was, when do I do Lapidus for hallux valgus? I don't do Lapidus for hallux valgus. So the answer is not. But that's me. I know if I go to US, there'll be a lot more.
Yes, right. So, so it was a wonderful interaction with you, Mr. Mark, and Dr. Raja, Paolo, and everybody else. I guess we'll have to wrap up quickly because it's already 1 a.m., is it, in Australia, Melbourne? Right.
Yeah.
And Mr. Mark, I'm sure you're supposed to operate actually in a few hours at 5 or 6 o'clock in the morning. So
yeah, not to. I have an all-day list starting in a few hours, so I might have to fall asleep soon. But it's funny with the time, isn't it?
Yes, it is actually. So
well, I want to thank you, everybody, for your listening, and thank you for inviting me. And I hope that we can do this again. But what we might do later on is maybe a whole session, maybe on hallux valgus or something like that. Maybe
yeah, sure.
Later on in the year or something.
So, Mahendra sir, are you there, Mahendra sir? Hello, Dr. Mahendra Kuchatkar? No, he'll be joining. So thank you, Mark, sir. It was a wonderful thing. and a wonderful presentation. And similarly, our panelist, Dr. Raja sir, who is actually father of minimum invasive foot and ankle surgery in India, and Dr. Abhishek Kinney, who is a friend of mine, who does a wonderful work as well. So thank you, our panelists. Thank you, Mr. Mark, once again, our past president of Asia Pacific Foot and Ankle Council. It's been a pleasure and an honor to have all of you on board. And thank you so much.
Thank you very much, and
Thank you.
all the best, everybody.
Yeah, I also.
Thank you, Kumar.
Yeah, bye, bye, bye.
Okay, see you soon.
All right. Thank you, sir. Bye.